All right, so I'd like to introduce Karen Davis, she is a professor at the University of Toronto and heads the Division of Brain, Imaging, and Behavior Systems Neuroscience at the Kimball Research Institute. She pioneered electrophysiological and brain imaging approaches to study pain and treatment outcomes. Dr. Davis has given more than 170 lectures, published more than 170 papers with 16,000 citations. Her TED Ed video has 1.6 million views, and I imagine probably a couple more after her talk today. She was a counselor of the International Association for the Study of Pain and chaired a task force that published recommendations regarding brain imaging to diagnose pain. She has been inducted into the Johns Hopkins Society of Scholars and the Canadian Academy of Health Sciences and is president-elect for the Canadian Pain Society. Awesome.
So thanks for having me here, and it's actually really a pleasure to always speak to a crowd of predominantly clinicians and healthcare providers. And I assume probably everybody here but me actually sees patients, interacts with patients and treats patients. I mean, we see patients in my lab, but only in terms of research. So this is really a pleasure to be able to interact with people who are actually at the front lines. So my talk is actually going to be in kind of two parts. I'm going to be talking kind of more basic science in the beginning. So if you're glazing over too much data, just hold on, because then I'm going to swing into in the second half another topic which might be more engaging for you, which has to do with my work involved in thinking about the neuroethics of using brain imaging to diagnose pain. Okay, so let's start with this. So actually, by show of hands, so who actually is a healthcare provider here that actually sees like everybody? Okay, and you're all in completely different areas. I guess many of you are physios, some are psychologists or psychiatrists, other types of healthcare providers. Whatever your specialty is, I'm sure you're all faced with maybe not this exact number of treatment options, but patients come to you and you probably still have to figure out what's the best way to treat that particular patient. Is that right? So is this what you do? I don't know if you can see that. It says, I want a detailed analysis, your best educated guess, and then round it out with some wild speculation, right? Yeah. But the longer you've been in practice, you actually have a great deal of experience, and probably your best educated guess is probably pretty good. Because it's trial and error, and so that's pretty good. But can we do better than that? So my lab and many labs are now trying to come up with kind of biomarkers so that one day we will be able to have additional information that might guide these treatment decisions. And I'm going to talk a little bit about something I call the dynamic pain connectome, and hopefully some of these biomarkers, not just within the brain, but other sorts of biomarkers, will hopefully lead to us being able to generate kind of a report that says, what is the likelihood in that particular patient for a variety of different treatment options of having success. And so then, it might spit out and say, okay, for this particular person's brain and all their behavioral findings and everything we can measure, we think this person should go to CBT, for instance, and not have brain stimulation or something like that, right? So this is where we're trying to head. So what are the problems, and why do we need this kind of an approach? And I'm going to be talking a lot about the drive towards understanding the individual patient. Okay, so the truth is we have a lot of things that can help some patients quite well, but many patients don't do well, and even the ones that do well sometimes have to stop whatever that treatment is because of some side effects. So why is that the case? Well, one of the problems is the way that all sorts of approaches in medicine come about is because we try to acquire data, and we have this G2I problem, which stands for group to individual. So we do all this research, and drug companies do all these studies, and we look at the effects of surgery and all sorts of manipulations, and we spit out data that talks about, on average, what happens in a group. But you're making a decision on the patient that's in front of you, right? So there's a lot of potential treatments that probably got thrown out because it didn't show great efficacy at a group level. But in fact, it might have been very, very good for a minority of patients. So we have to rethink how we evaluate these treatments. And many people have been talking about this for many years. It's the classic case of lumping versus splitting. So we in the research area where I'm working in, we're talking more and more about really trying to understand what's happening individually, and not to throw things out because it didn't work for the majority. So what we've been doing in my lab for about 25 years is looking at this question of individuality and trying to understand, why we have different pain sensitivities. I'm sure if you turn to the person next to you, talk about your pain experiences, you'll probably have different experiences. You probably all know family members or friends that are very stoic, and maybe others that aren't that way, and maybe they have different abilities for coping and resilience. So we're trying to understand why that is, and if we can understand that, we can maybe work more towards this personalized approach. So this is an example I like to give because this is what actually happened to me in my hospital where I work. They make us get a flu shot every year as staff. They don't want us getting the patients sick. And so, I'm in line every year, and there was one year where there was this nurse in line in front of me, and she was like really, really upset. She didn't want to get this flu shot, which I thought wasn't that big of a deal. And even though there were people like this that were in front of her that looked perfectly fine, it doesn't hurt that much, some people show this other kind of response, right? So, and it doesn't matter what your educational background is, what your training is, pain varies. So to the exact same stimulus, the exact same needle poke, people are going to experience it differently. So how can that be? So really it means that our brains are different. Something is being interpreted or not modulated or modulated more in our brains differently for all of us. And that's what we're trying to understand in my lab, that connection between what we experience and what our brains are signaling. So, so what we're trying to figure out is the pain code in the brain, but for individuals. Okay, and if we can figure that out, then we can figure out how to tap into that and manipulate it and change it. Okay, so I'm not going to get into all the details of which brain areas are what, but just to kind of put things into kind of categories that I think of your pain experience arising due to all these circuits and networks in the brain, kind of binned into two major interacting systems. The system that senses input coming in, and that's mediated by a whole bunch of nociceptive pathways. Let's see if this works. Good. And then these are kind of the top-down descending controls that modulate those signals. And the interaction, the health of those systems is what gives us the pain system. And there's a whole bunch of very interesting behavioral measures and tests of the health of these systems, and we've used these kinds of tests, and other people have as well. So there are ways that we can measure these things and tap into the health of these systems. There's also a whole bunch of exciting brain imaging technologies out there now, and everybody is seeing these fancy pictures. But the ones I'm going to talk about are functional MRI and MEG, which stands for magnetic encephalography. And all these different techniques have advantages and disadvantages, right? So there's no one technique which is the best technique for everything. Some of them have better ability to separate out and have accuracy in space, and others in time. So many groups are now trying to kind of use multiple approaches to kind of get the space and time accuracy of what's going on in the brain. So people can look at function in the brain using functional MRI or positron emission tomography. You can look at receptors in the brain. You can look at the anatomy and the connectivity in the brain, and then you can look at gray matter. So there are lots of things that you can do. So I'm not going to get into all the details of how you actually do this. If you're interested, there's like, this is a one-pager in pain. They have this thing called Pain Pictured now in that journal, where you kind of produce kind of a poster, and it's supposed to give kind of an overview of a concept that's easy to digest for people who aren't in the field. So we wrote one on brain imaging, so you can look that up if you're interested. It came out last year. But what I want to emphasize is what we're doing in our brain imaging experiments is no longer just looking at what areas of the brain kind of light up or get activated when somebody's feeling pain. But that's what we did for the first 20 years in brain imaging. Where we've gone in the last 10 years is really exciting because we're doing more than that. We're trying to look at how the brain communicates from one brain area to another, from one network of the brain to another, how maybe information is communicated in synchrony or not in synchrony, and that has a lot of implications for whether that information is being efficiently transmitted around the brain. So we can look at this temporal variability in the brain. People use EEG, but you can use fMRI to do this as well. So what we've done over the last 20 years or so in this area of individual variabilities, we started off trying to understand acute pain before we can move into chronic pain. So I won't go through all this data, but just to say that we have found that you could use brain imaging to kind of find a signature of different types of metrics of pain sensitivity. So your threshold for pain, your tolerance, habituation, all these sorts of things. And we've looked at sex differences as well. So you can look at gray matter, you can look at white matter, you can look at brain activation, and in all these cases, you can find links to how sensitive you are by these metrics and how little or much or effective information is flowing around in the brain. We've also done a lot of work to show that all of this stuff is not just fixed, but it can be somewhat modulated based on a situation, a behavioral situation, and is also different based on different aspects of people's personality. These last two kind of buckets of things we've been looking at is something I will just give you a little bit of background on because I think it's pretty cool stuff, and it's also what's talked about in that TED-Ed video that was mentioned. So I'll show you the link to that later, and if you glaze over this now, you can watch a cartoon and get it all in 4 minutes. So it's a lot simpler. So where does this all fit into a system? Well, I'll take a step back for a minute. David Yarnitsky and others have kind of put forth this idea that people sit on a spectrum, behavioral spectrum that he calls the nociception spectrum, from people who are kind of anti-nociceptive versus pro-nociceptive. So people over here have they have a lot of temporal summation of pain, which is when you just give repetitive stimuli and you kind of have a wind-up effect. And they have a less efficient, what's called CPM, or conditioned pain modulation. So they don't have as much modulation going on, whereas people over here are able to dampen their system, and they have higher pain thresholds. So that was all defined based on behavioral tests. What we've done recently in our lab is try to figure out if you can categorize people on that kind of spectrum based on what their brain is doing. And I wouldn't be telling you about it if the answer wasn't yes. So basically what we did is we used a type of brain imaging approach called functional connectivity analysis, which is basically an approach that just says, okay, how much is this area of the brain talking effectively to this other area of the brain? So looking for synchrony of activity. And so we looked at two systems. We looked at the that ascending sensing system. So this is information going from the thalamus to the primary somatosensory cortex. And then we looked at the efficiency of the top-down or modulation system down to the brainstem. And so what we found is each dot here is an individual person, and what we found is that some people had a stronger sensing system than modulation system, and other people had a stronger modulation system than sensing system. So we thought, well, is that just kind of by chance? Is that really meaningful? Well, we then took each of these people, we ran them through some behavioral tests, and we found that the people whose brains we now said were pro-nociceptive actually showed much greater temporal summation of pain, which is a sign of wind-up in the spinal cord, than the people who had a stronger modulation system, who had very little of this summation effect. So the brain was showing us what the behavior was telling us as well. So we were starting to get an understanding of the brain imprint of this behavioral effect. Okay, another example of individual variability is what we've been calling this an AP phenotype spectrum. So what we kind of stumbled across this by chance. Over 10 years ago, at the time, Dave Siminowitz, who was a student in my lab, was interested in studying how pain can impede people's ability to do cognitive tasks. But the data was really messy, and it was all over the place. And we realized that we had two types of effects. So we had people that we now call P-type, which is what we thought everybody was, which is if they're doing a task and then we deliver painful stimuli, their task performance is impeded. So they get slower and they make more mistakes. And we thought everybody would be like this. But it turns out half the people that we studied were what we now call A-types, or attention dominates versus pain dominates. And their task performance not only was good when they were receiving painful stimuli, it was actually sometimes better. And so, the subjects used to say to us, actually, when you were zapping me, it motivated me to try harder and to concentrate more on getting it right. So A-type individuals. And over a series of, now it's up to about 6 studies over the last 12 years, we've looked at these A-types and P-types, looking at their gray matter, their white matter, their connectivity, all aspects of the brain that we could look at using MRI. And we found that in each type of metric of the brain, the P-types and the A-types were different. Okay, so it was reflected in these networks that we were looking at. Okay, so that's the spectrum of, and it's actually, it's not so simple. It's not like people are clearly A's or clearly P's. There is a spectrum. There's a kind of a fuzzy middle. So that's what happens when pain is impacting or not impacting your ability to do a task. What if there's no task? What about just sitting around? I had another student, Aaron Kusi, he's up at Stanford now doing a postdoc, and he said, well, what about people's ability to just mind wander, right? Mind wander away from pain, and is that linked to kind of a coping mechanism, a coping ability? So we did a whole bunch of studies, and this was his PhD, looking at mind wandering in the brain. And again, we found this dichotomy or spectrum of people that we had either what we called high IAP or the high intrinsic attention to pain. So when we zapped them, after each kind of zap, we would say, okay, to that last stimulus, how much were you mind wandering away from it, or how much were you attending to it? And people used to rate, and we got all these ratings. And then we had these people who really, really had very low attention to pain. They would say, yeah, I wasn't thinking about it. I was thinking about something else. And we thought, well, maybe that's just what they're rating. Like, is that really truthful? Is that really true? So then, of course, we did all the brain imaging stuff, and I won't show you all the boring graphs, but we found, again, their gray matter, their white matter, their connectivity, things were different in these mind wanderers versus the non-mind wanderers. But what the most important thing that we found that was different was something that was new in the field of brain imaging. It was the ability to look at not just the connectivity between brain areas, how in sync they were, but how dynamic that connectivity was. How flexible was that connectivity? And it turned out that the mind wanderers not only had a strong connection to their pain modulation pathway, but that connection was very dynamic. So it's kind of like, it can go either way. So people could really tap into it and tap out of it. It wasn't rigid. So this was really, really cool when we found that. And it led us to develop this concept that we call the dynamic pain connectome, which was developed to describe how the brain tunes out pain. And I won't go into all the details, but it ends up involving a whole bunch of networks in the brain that back in the days where people used to use the term the pain matrix and things like that, which is kind of the main sensory areas of the brain, turns out that all these effects that we're seeing is not just due to those, ascending pathways and descending modulation pathways, but really taps into this salience network and what's now known as the default mode network, in addition to all the other stuff. And so how does it work? Well, first of all, so I'll leave that for now. I'll come back to it in a few minutes. But we're going to be looking at now how all that might be abnormal when you have chronic pain, right? So I'm going to be talking about both structural and functional abnormalities. So really, we're talking about hardware and software of the brain. Okay. Again, I'm not going to go show you dozens of studies, but basically in one picture, what we found is that if you look across now hundreds of studies of chronic pain and you put it into this dynamic pain connectome model that we developed, it turns out the areas of the brain that show abnormalities either in gray matter or activation or connectivity did fall into these same kind of networks that we found that designated this mind-wandering effect. So the default mode network, the salience network, and all sorts of sensory motor areas of the brain, as well as the descending controls, of course. So the idea then is we have an understanding of where in the brain things go wrong, what might go wrong in terms of this dynamic, or what might we want to enhance. Maybe, should we be making everybody into these mind wanderers? Would they be better off at coping and handling pain? So we want to look to see whether or not we can change people with bad wiring to have good wiring, and that might lead to better effective pain treatment. So where should we be looking, and what should we be tapping into with all these potential treatment approaches? So, of course, there's the structural stuff, which I'm not going to get into, but because we've been doing more and more work lately looking at function of the brain. So you can have a problem that you try to fix in terms of within an area of the brain, how the neurons are functioning in that area of the brain. And there's ways of looking at that. But you can also look at this communication between areas of the brain. And in addition to this regular connectivity that people used to talk about, we can now look at this dynamics of the system. Okay, so I'm just going to give you a couple examples of how we've been looking at patients with chronic pain to see where these abnormalities are, and that maybe this will show us where we should be trying to modulate to help their pain. So one thing that we stumbled into is that we found that these networks of the brain that we give names to, the default mode, the salience network, that we give a name to these networks because the areas of the brain within those networks have very strong connectivity to each other and very weak connectivity to these other areas of the brain that are in another network. But what we find is patients that have chronic pain, and we've now looked at many types of chronic pain. These are patients with ankylosing spondylitis, but I can show you the same thing with multiple sclerosis or many other types of pain. We start to see this cross-network connectivity. So the networks should be kind of connected to each other separately, but now you've got this communication between the two networks, and the amount of that cross-network connectivity is worse and worse in the patients that have a lot of pain or that have a lot of functional disabilities related to their pain. And that's the same thing in patients with MS. So we have now an understanding that these areas now, everything's kind of fallen apart the networks aren't modular anymore. And we've also seen that factors like resilience play into this. So this was a study in both healthy individuals and patients with chronic pain, and we find that that resilience is a factor in shaping this cross-network connectivity. So people who were very resilient didn't have as much of that. So it gets very complicated. We can look at catastrophizing and lots of different personality factors, but basically it's a complicated system. So if you just look at one factor, you're not seeing the whole thing together. So it really is humbling to know that there's a lot that we have to take into consideration. So what can we do then in moving forward to talk about finding a treatment? And one thing we can do is look at recovery after treatment over time and of these systems I've been talking about, and that might give us clues as to maybe which patients should have that treatment and which should not. So one thing that people in my field that are doing all this research I've been debating a lot about lately is this issue of biomarkers. Biomarkers of pain, biomarkers of chronic pain, biomarkers of treatment outcomes, etc. But not all of us, not everybody in the field is a brain imager. There are people who do psychophysical tests. There are people who look at immune responses. They look at blood. They look at all sorts of things. So the question is, what type of biomarker should we be looking at? In my lab, we've just been looking at brain versus behavior, and we're finding that we can see. I won't go into the details, but in this example of these are people that had a peripheral nerve injury, and we looked at them over time as they recovered after surgery, and a predictor perhaps of people that got better had to do with what was going on in their insula, but also whether or not they had a lot of pain catastrophizing to begin with. So the pain catastrophizers did not recover as well. So there's a lot of things to think about. Most recently, we've been getting a lot closer to this idea of a predictor or a biomarker of treatment outcome, and it's pretty exciting. So I just want to tell you about two studies that we've done in the last couple of years. This first study was in collaboration with Moji Hodai, who's a neurosurgeon in my hospital. We do a lot of collaborations, and we've been looking at trigeminal neuralgia for many years and what's gone wrong in the brain in trigeminal neuralgia, and as well as, of course, the trigeminal nerve. And she does gamma knife surgery and also microvascular decompression for these patients. And we've been using a lot of approaches to try to come up with models and look at factors individually, but also use high-level machine learning and models to try to come up with predictions of treatment outcome. What we found, the slide's not there. Okay, so I missed the slide. But basically what we found in this study is that we found that patients who responded to either one of these surgeries had a reversal of their abnormalities in their brain, in the insula, and also of the abnormalities in their trigeminal nerve. But the patients that did not get better after the surgery showed no reversal of these abnormalities. So the question is, can we look at the abnormalities before surgery? Were they higher or lower? Can we predict which patients should even go for this surgery or not? Can we predict who's going to do well? So I'll give you that answer in another 5 years because we're doing all this machine learning to get the answer. But while we're doing that, we're also doing studies in these patients that have ankylosing spondylitis. We have many more of those patients, so it's a little bit easier to do that. And these patients are generally relatively healthy men who are usually in their 30s or 40s. The problem with trigeminal neuralgia, the patients are quite a bit older, so there's a lot of comorbidities. So it's a little bit harder to work with. So we've been looking at these patients, and we've been, this is just last year, my student Josh Cheng developed machine learning to try to come up with models of what's going on in those patients. So we have to take a step back before we can look at treatment outcomes. We have to say, well, before we do that, we're creating these models. What are we going to throw into the models, right? Garbage in, garbage out. We have to be able to. Anybody can do these machine learning models now. They're pretty. I won't say they're easy to do, but they're becoming more and more standard. So one thing we thought a lot about was this issue of state pain and trait pain. So how many of you have patients that come in to see you and they say, oh, you say, how's your pain today? Oh, my pain is 8 out of 10, right, today. But how was it yesterday? Yesterday, not so bad. Yesterday, maybe 2 out of 10. Or if you see them in the morning, they might report a different amount of pain than if you see them later in the day, right? So we had this problem. People were coming in, doing all this assessment, and then we throw them into the MRI to scan their brain. And the clinicians send us these patients, and then we have these criteria, and okay, we only want people that have pain above a certain amount. And then they'd come in, and some of them would say, actually, I don't have any pain today, or my pain's a 1. And it's like, oh, well, that's really frustrating. So do we keep you in the study? Do we take you out of the study? I don't know what to do. So everybody, their pain varies. Their pain varies day to day. Their pain varies different times of the day. So we started to think a lot about, well, what are we doing in trying to correlate what we measure in the brain with what they say their pain is at the time they come to see us? Sometimes their pain goes down when they come to see us because we're a compassionate or empathetic listener to their pain. Other times their pain goes up when they come to see us because they have to lie in the scanner, and if they have back pain, then that makes their pain worse. So what do you do? What do you use? So, and here's another example of the circadian patterns of pain just over, hour to hour. Of course, some people have worse pain at night or in the morning or whatever. So we have to be aware of that. So in this study, we said, okay, well, let's really put everything into the model so that we know what we're talking about. So we put in that state and trait thing. And then we also had to decide, well, what about the different types of pain these patients have? Patients with ankylosing spondylitis, people thought that it was an inflammatory pain for forever. And then about 10 years ago, we did some studies and we found that actually there's a neuropathic pain component in about half the patients. So we categorized their type of pain. And it turns out that when we did these machine learning models for state pain and trait pains separately, and for neuropathic pain and inflammatory pain separately, the models were driven by the patients with neuropathic pain. Those were the better models. And the state pain, I won't go into the details. These are showing the connectivities between different brain networks and areas that were the strongest ones that modeled these kinds of pains. They were similar, but they're not the same. Okay, and it was the dynamic functional connectivity that really drove the models, not the kind of standard static connectivity. So it depends what you put into the model is what you're going to get. And so, I'd say the devil's really in the details, that you really need to think about what characteristics of pain you're going to put into your model. Current pain, average pain, neuropathic pains, intensity, quality of pain, unpleasantness, all these things. And why does it matter? Well, not only does it matter in terms of making a good model, but it matters because, and this is leading into the last few minutes of my talk, I'm going to talk about ethics, is that if people are going to use these models for making decisions about people's pain, you can underestimate people's pain or overestimate their pain if you're trying to use the brain model to say, I think my brain model knows more than your pain rating as to what you're really feeling. So that's a whole neuroethical problem right there. But these models will either underestimate or overestimate the pain depending on what goes into the model. So these really do have a lot of implications. Okay, so if you construct these kinds of approaches, can we then predict treatment success? So this is what we've been trying to do to get towards that personalized medicine. We're trying to measure everything we can and categorize the patients as much as we can, and then we look at whether or not a certain treatment helps people or doesn't help people. And then we look backwards to see what we measured before they had treatment. It turned out to be different in the responders versus non-responders. So this was that study I mentioned about the trigeminal neuralgia, that it turns out that if we do these models and we look at the trigeminal nerve, we can predict to a certain degree the likelihood of a poor response to trigeminal neuralgia surgery. This is in a very small sample, so this is just the first try at this, and we're collecting a lot more data, and as I said, doing more machine learning. This is a paper that just came out a few months ago that we're quite excited about. So I collaborate in Toronto with Anuj Bhatia. So he's an anesthesiologist, pain doc, and he's been running these studies to look at the effect of ketamine, but ketamine done in a very, very controlled manner. Where it brings people into the hospital for 5 days. They get a titrated infusion of ketamine, titrated to a dose where there's no psychotropic effects. And it's very labor intensive, very costly. He has approval from our provincial government in Canada to do 2 patients a month in this way. It's very expensive, and it's a big trial. So we were lucky to be able to do a little bit of science. And the idea is that, ketamine is an NMDA antagonist, and this temporal summation of pain that I mentioned earlier depends on this kind of NMDA system. So when you give ketamine, you're affecting this spinal cord wind-up temporal summation of pain system. So that gave us a really cool tool to look at all the things I talked about in the first half of my talk. So turns out that about half the people did very well with ketamine, half the people did not. So we have responders and non-responders, and it turns out that the temporal summation of pain, the pre-treatment level of temporal summation of pain was very high in the responders. So, and if we looked at the brain, the pre-treatment amount of connectivity to this modulation system was higher in the responders. So why is that? So this is our idea. As I said at the beginning, we have a pain sensing system and we have a pain modulation system. And if you give ketamine, which blocks this pain sensing system, you're going to only get an effect in the people who had an abnormal pain sensing system to begin with. If there was nothing wrong with that to begin with, if their temporal summation of pain was fine, then giving that drug that blocks that is not going to do anything. So that's in fact what we found. So this kind of blocks this overactive pain sensing pathway, which was acting to kind of dampen the modulation effect. And then the bottom line is you're also only going to have an effect in these patients if their pain modulation system has the capacity to recover. Okay, so that just gives you a sense of what we've been doing. So how would we move forward then towards effective therapeutic targets? Do we target the brain or do we target all these behaviors? Don't know yet, but we certainly have now some insight of whether you should be blocking a system or stimulating a system. And it's not just with surgery or drugs. Obviously, a lot of other sorts of therapies like CBT, we've done some work with CBT, and we see how that changes the brain and taps into brain circuits as well. So, when I was a student in high school, we were taught that the brain doesn't change. It is what it is. You've got what you've got. We now know that it has tremendous plasticity, and that we can tap into to try to repair the brain. So this leads to the last few minutes of my talk, which is, if we're going to move in this direction and look at pain biomarkers, we can look at them for diagnostic purposes or to try to predict whether people are going to do well with the treatment or not. The problem is with the first case, with the diagnostic case, and that's because, as we all know, pain by definition is subjective. It is what you say it is, and arguably it can only be truly known by self-report. The problem is a lot of people aren't honest, as you probably know, and there are people who can't communicate that. Babies, people who have other issues, and they can't communicate. So that's why people want this brain biomarker to try to use to try to get a handle on what people are feeling. But it's important to know that the proxy of using brain activity instead of asking people what they feel is problematic, because I can give you many examples, but you can think about people under general anesthesia. They're not feeling any pain, they're out, right? But I can stick my electrode into the brain and record nociceptive activity in the brain. So there is this disconnect, right? So it's not the same thing. Pain is subjective, so do not equate the two. Okay, so, but what if your medical legal system requires that you undergo some sort of chronic pain brain test? And this slide I made up so many years ago when it seemed like this was science fiction, but this is actually where things are going now, so it's kind of scary. So you're really kind of saying, well, do we have a lie detector test? And you're saying to your patients, I think you're dishonest, so you need to go in the scanner to prove you have pain. And, you know, doubting that self-report, that creates some mistrust, and it's pretty stressful, and not only to the patient, but their whole family gets this idea that, oh, maybe my loved one is making it up or something like that, right? So it's really problematic. So I won't go through the details of this, but there was a legal precedent a few years ago with a patient that people tried to use brain scans to validate their self-report, and everybody has been very upset about this since this happened in 2015. And I've written a lot about it, so I won't go into it today, but the bottom line is this concept of a brain painometer has emerged out of that, and there's a lot of problems with that, and I don't have time to go into the details, but finding pain in the brain is like finding Waldo. There is no specific pain area in the brain, and we've written about this extensively. Every area of the brain that kind of lights up or has nociceptive neurons also has other sorts of functions going on in that area of the brain, right? So nociception just kind of doesn't have its own real estate. It shares space in the brain with all these other systems. So this is the problem. You know, pain does activate the brain, but if you throw somebody in the scanner and you get all this brain activation, it could be due to pain, but it could be due to a lot of these other systems. So this is what's called the reverse inference problem. And so that's a problem of developing this brain test using MRI. The other thing is people are not paying attention to all the other aspects of the pain experience when they do these kinds of tests. And all this individual variability that I talked about at the beginning of my talk is not being taken into consideration in developing these tests. There's tons of technical issues, physiological issues. I won't go into all this sort of thing. But so I'll just mention that even if you could do these sorts of things, there are ethical issues, societal issues, like who has access to this, who's going to pay, where's the machine, what about people who have a pacemaker and can't have that, who's going to protect the privacy of the data to make sure that people don't lose their job or their health insurance or this sort of thing. It's similar to the protections that had to come about for genetic testing. So, and who's going to talk to the person and who's going to counsel them about the fact that maybe they have a bad brain, right? So these things need to be talked about. So, and if there's false negatives, then obviously people really suffer. False positives aren't as bad, but it hurts the system in terms of finance. So if you're interested in that, just Google me. I've written extensively about this issue, but most importantly, we spent a few years heading a task force of the IASP to look at this question, and we published the results 2 years ago, I guess a year and a half ago now, in Nature Reviews Neurology. So this is our recommendations, and I won't go through all the recommendations, just to say that we considered, do we need them? How good are they? We considered all these questions about biomarkers of pain, and we're still talking about this. I'm involved in an NIH group now looking at biomarkers of pain. The bottom line is, and those considerations are up on the NIH website if you want to look at that, because we've had workshops on pain biomarkers there. But the bottom line of our ISP finding is that we did come up with a list of criteria that would have to be fulfilled if some sort of brain test would be valid. Currently, there's nothing that even comes close to fulfilling these criteria. And the bottom line is, even if it did come along, we still have to take into consideration the social implications and the effects of the false negative findings. So our bottom line was that what you should be aiming for with these kinds of biomarkers is not to validate or not to invalidate people's self-report, but to guide personalized pain management. So it's more to really make decisions about who should get what kind of treatment, match the brain to the treatment. That's the bottom line. And I won't go through all those other points, but just to say, you can read it. You can read it. Well, I can if you want, but it's a lot of words. Okay, so brain imaging shows promise in the assessment of risk factors for chronic pain and in identification of the mechanisms that, so basically, it's promising to understand the mechanism. This is all in the paper. And that we really need a lot more technological advance, but things are moving actually very, very fast. Mostly, this issue of large-scale data acquisition is really important because, again, it's this issue of lumping and splitting. People are coming out with lots of data, but on relatively small samples, and that's not going to be a solution for everybody. The brain-based biomarkers should be only used as an adjunct rather than a replacement for subjective reports of the pain experience. Brain imaging as legal evidence of an individual's pain is not advisable until we can kind of figure this out. And again, as I said, these measures should only be used at this point to understand brain mechanisms and move us forward towards effective pain management. Okay, so don't do this, do this. So that's what we want to do. We're concentrating on trying to develop pain biomarkers to treat people, not to say you're lying about your self-report. Okay, so the bottom line is there's a lot of bad things about brain imaging that could happen from an ethical point of view, but the pros are certainly worth pursuing this, otherwise I wouldn't be doing this for my career, to improve diagnostics, improve treatment, and develop personalized medicine. And if you're interested in the broader concept of neuroethics and bioethics regarding pain, I just co-edited this book that just came out, and you can see some great authors, and so that's available. And we're up to 1.7 million views, so it's actually a pretty funny video. The animator, when he made this video, my first impression was, are you kidding me? This is like silly and stupid. And then it turned out that I'm just old and not, at the time our daughter said, no, this is really funny. This is really good. It's like, all right. And I guess 1.7 million people like it. So I think some of my clinical colleagues say they tell their patients to go look at it because it's fun for them to watch. So there you go. And that's it. And I'd like to thank everyone in my lab and all my funders and take any questions. But I'll leave this up if you want to write this down.
All right, so I won't lie. I love seeing that the room is still full, and
it's dinner or me, so I'm flattered. I'm very flattered.
So we do have time for some questions, but then after the questions, please give me 5 extra minutes because there's actually several announcements. So any questions? Anything online? Yeah. Okay.
Online, they'd like to know, could you give an easy definition for state pain and trait pain?
An easy definition? Oh, okay. Well, as a non-clinician, I would just say what we do operationally is state pain is the pain that your current pain that you're feeling at this moment. We ask people, what's your pain right now? The trait pain, it's the way we're doing it now is when patients come to the clinics, they tend to fill out these questionnaires that say, what was your average pain over the last month? And that we just use as their trait pain. That's really not a good way of doing it. What we're doing now and what a lot of people are doing now is everyone's got apps, right? So patients now, they rate their pain on an app many, many times during the day. And then there's ways that we could then decide how to determine what their trait pain is based on an average standard deviation, whatever, over a long period of time. So.
All right, anyone? Okay, we got one here in the front. I like how reliable you are.
Thank you, Dr.
I'll
Davis.
put
That's
this
great.
up. Yeah.
Distraction is a big go-to strategy that people teach in the clinic, and my colleagues and I have landed on the side against teaching distraction as a daily coping strategy, but I was curious by the things you explored in your clinic on whether you have any commentary on, and that this is where you're trying to go with your research, I saw that, but currently what you know, whether we should encourage distraction in some and discourage in others based on something we can latch onto and what we see and how they talk about their behaviors?
I think it's fine to encourage it. I mean, I don't see any downsides side, except that I think what we're finding is that people, they're wired in a certain way, and some people without that instruction, without that training, might be naturally just distractible or being able to use that as a strategy. Other people, I don't know, maybe we can switch. Like when I first found this A and P thing, the first thing that the clinician said to me and the psychologists that work with me said, can we turn a P into an A? And we started to do this CBT stuff, and it's like, well, I said, isn't that what you do with CBT all the time? They said, yeah, but not everybody responds to CBT. And it's like, oh, well, maybe you can't turn a P into an A, but maybe you can tweak them a little bit, because there was a lot of fuzzy middle. There were people at the extremes, and there was a lot of fuzzy middle. So maybe you can pull people a little bit to one side or the other. And maybe it's a life experience. I mean, I also interact a lot with pediatric pain researchers, and I interact a lot with Christine Chambers and other people in Toronto, and what they're doing for like the needle pain in kids and all this kind of distraction stuff. I think it's good. When I get a shot, I look away. I'm looking at something else. Yeah, helps me. So, yeah.
You talked about where people are on the spectrum, the different types. Have you looked at those people over time? Is there much variability in an individual over time?
Yeah.
With those kinds of traits, or are those more immutable than that?
Yeah, that's a really great question. In fact, that's what kept us out of the highest journals with those studies, because they wanted us to prove that because we called them phenotypes, and they say, well, you only studied them once, how do you know? And it's like, well, we just can't do the study for another 3 years and keep bringing people in. But in fact, what we did do in one of the studies, we did look at them twice, because we studied them outside the scanner, and then also they did the same thing inside the scanner, and there was consistency there. So at least at 2 time points, people were internally consistent. But we haven't looked over time. Yeah.
All right, thank you very much.
Yeah.
This is going to sound crazy, but I'll ask it anyways. I'm a big fan of the brain, but
I got one too.
Have you considered we have this obsession and this focus on imaging the brain, but other systems in the body for finding pain, the heart, the gut, cellular level, because it probably is more than just the brain involved.
Yeah, absolutely. So, we chase down. A lot of people chase down the heart rate variability issue, not just for pain. I also do some work in the concussion area, and we thought that would be an indicator of concussion recovery, and it turned out to not really pan out. And So I think sure there are, the immune system, right? I did a lot of work. One of the two speakers ago was talking about irritable bowel syndrome and rectal distensions. I did those studies while imaging the brain, right? And so there's the brain gut interaction is quite profound. So I mean, your final perception is obviously in the brain, but what contributes to that is whole body, certainly. Yeah. And a lot of these, so-called biomarkers. So this NIH biomarker workshop that you can see all those lectures. It was an amazing 2-day workshop, and we're coming up with recommendations from that workshop. We're writing it up now, and only a very small segment of that 2-day workshop focused on brain imaging. Like there was just a handful of us that were brain imagers. Everything else was blood-borne, immunological, psychological, all sorts of things. So, to have to put somebody into a scanner to make a decision, that's a pretty expensive and time-consuming thing to do, with a lot of expertise required to interpret that. If we can come up with a very easy behavioral marker. So that study, that ketamine study, the temporal summation of pain was just as good a predictor as looking at brain connectivity. So, I can measure temporal summation of pain in 60 seconds. So why not just do that, right? Yeah. Yep.
Okay, any other questions? All right, awesome, well, thank you so much.
Thank you.